Thank you. Thanks, Alistair, and thanks everyone for your attention. So I'm here to talk about, as Alistair said, algorithmic bias and some of the work we've been doing at the University of Birmingham to try and tackle this. So I guess I'm aware that I'm in a postprandial, post-lunch slot after a break as well. So let's have the bottom line up front for those of us that are happily kind of enjoying our lunch and maybe feeling a bit more drowsy than normal. So AI algorithms can be biased. That's a really important thing to recognise. And if we use a biased algorithm in healthcare, that could worsen pre-existing health outcomes and pre-existing health inequalities, but it could also cause new health inequalities. And also important to recognise that these biases can occur for a whole bunch of different reasons, but problems with the data that is used during development is a really important issue to solve. And so we have created a set of recommendations called Standing Together, which are focused on encouraging data diversity, inclusivity, and generalizability. And we hope that these recommendations will lessen the impact of algorithmic bias. So I hope I don't have to convince anyone on the call that now is a really exciting time to be working in healthcare in AI. There's a lot of really increasingly interesting and amazing technology out there, and work led by my colleague Dr. Liu a few years back now. The world's first ever systematic review of meta-analysis showed this amazing potential, even back in 2019, of algorithmic systems to match or in some cases surpass the performance of specialist clinicians at various different clinical tasks. And if we fast forward just a few years to the kind of present day, where we're seeing an increasingly amazing multimodal performance of particularly generative AI systems like Google's Gemini, but also ChatGPT, Claude, etc., and an increasingly mature market for AI products. So products available either for use now or at least in the kind of later stages of development and into the kind of testing and implementation process. But unfortunately, the kind of lofty claims are not always fully supported by evidence. So that same work led by Dr. Liu back in 2019, well, okay, the headline finding was that these tools have an ability to match or maybe surpass clinical performance. But actually, the real headline finding was that very few of these studies presented externally validated results, which means that they maybe presented evidence for a kind of a narrow application of this tool, but not into the wider context in which that tool was going to be deployed. So we had evidence of performance in a very small area, but that wasn't necessarily extrapolatable to the wider clinical context. And also there was relatively poor reporting of studies, and that all of this added up to be limiting of our ability to actually interpret the studies. I think putting all this together, there was evidence that they were performing well, but that evidence wasn't very good quality. Now, we don't have to look very far outside of the context of healthcare to find examples of where AI has gone wrong. Now, if Google Maps directs me the wrong way around a traffic jam and I miss a meeting, that's kind of annoying, but that's nothing compared to the kind of real world misery that's associated with some algorithmic failures. So, for instance, algorithms to try and predict prisoners' rates of reoffending, systematically discriminating against Black people, or systems that many large companies might use to try and screen CVs or to screen job applicants, systematically disadvantaging those who have non-English sounding names or women. And that's before we consider the propensity of large language models and generative AI to just make stuff up. But if we look inside healthcare, we can see that this is actually a problem for medical AI too. So a whole bunch of different examples increasingly coming to the fore over the last few years. How about this example of a widely used sepsis detection algorithm in the United States? Now, sepsis detection, for those non-clinicians on the call, is a relatively sensible thing to do. We know that sepsis is a big killer worldwide. It's often unrecognized or under-recognized, and if missed in the early stages, it can then go on to dramatically increase someone's chance of suffering ill health or even dying from that condition. So detection of it early is definitely a useful thing to do. The problem is that this algorithm flagged nearly 20% of all patients going into the hospital as at risk of sepsis needing urgent assessment by a clinician, and still managed to miss 2/3 of sepsis cases. And I think just that sheer extra workload of flagging 1 in 5 patients as needing assessment by a clinician, whilst not really providing much benefit in terms of detecting unrecognised cases, has clear implications for alert fatigue, where clinicians maybe are getting more and more pop-ups on their computer system and maybe just ignoring them, and also clinician workload and burnout. Clinicians given even more tasks by these algorithmic systems. We also see increasing evidence of algorithmic systems which work less well for women, like this example of an AKI treatment algorithm, which was less accurate at detecting acute kidney injury for women than for men. And there's a whole bunch of evidence now that many AI systems may show racial and ethnic biases as well. The most widely cited example of this comes from work led by Obermeyer and colleagues back in 2019, which showed that a really widely used algorithm, which was used in the United States to allocate healthcare resources around states and healthcare institutions, systematically underestimated the sickness of Black patients, meaning that they were less likely to allocate treatment resources to neighbourhoods where there were more Black patients. And so those hospitals had less resourcing, they provided less good care, and potentially millions of patients suffered ill consequences as a result. Now, I mentioned generative AI earlier on, and I think it's important to recognise that these tools right now, it's a nascent field. These are rapidly developing. It's a new frontier for science. And these technologies, they're amazing. They have great potential, but they also have big problems right now. So in the medical context, there are a few studies now showing that many of these systems propagate outdated racial stereotypes. So many of the ways that we used to think back in decades past, that we now recognise to have their kind of foundations in systemic and historical oppression, racism, discrimination, those ways of thinking that we now don't really have anymore, or they exist still in the corpuses of literature used to train large language models. And then we find that these tropes are then recreated in the outputs of predictive models, of large language models. And again, because of the historical nature of the data they use to train on, in many cases, their results are not adherent to current best practice guidelines. And there are also substantial ethical and legal issues which currently just limit our ability to use these in healthcare. But I guess a key message really is that we shouldn't be surprised by any of this, because artificial intelligence is just a kind of mirror. It's a model. It creates a version of reality encoded in bits and bytes based on the data that we provide it. And those data are generated by our healthcare systems, our societies, and the way that we deliver health and care. And the models do exactly what they're meant to do. They faithfully reproduce those data in the kind of metaverse, really. And if we don't like what we're seeing in the mirror, then that's kind of on us to solve. I've mentioned algorithmic bias a few times now, and it's really important that we do recognize that algorithmic bias can occur at any stage of the AI lifecycle. So that's all the way down from the way that we select problems to try and solve, the way that we allocate treatment resources, the way that we allocate research funding, what kind of conditions we try and develop algorithmic solutions for. That can clearly bias. If we focus our development efforts on one small narrow area and we miss out a disease area that affects mostly minoritized people, then clearly we're not going to have the impact we want to see. Data collection and the data we use to develop tools is clearly very important, but also the way that we define diseases and clinical outcomes, and the actual nuts and bolts of what goes into our algorithms as we develop them, and also the way that we deploy those algorithms and monitor them once they've actually been developed. But we're going to focus the rest of this talk today on data because we think that's a really important thing to solve. Now, I guess one thing to recognize is that data sets can incorporate and concentrate biases from a variety of different sources. And that means often that the data sets contain are distorted versions of reality. I guess we all need to recognize that bias is inherent to our society at large. So we still have discrimination, oppression, marginalization, and these are manifest in really complex ways throughout our society, and they influence the way that people live their lives and the way they experience health and care services. So barriers to accessing healthcare mean that some people don't receive help, and other groups get worse care than the most benefited in society. And all of this manifests itself in the data that we collect, because when we provide healthcare, we keep records of what we do, and then those records feed into healthcare data sets, and those data sets are then used to create algorithms. And so the cycle perpetuates. But it's not just that, but also the way we record and capture data and categorize data in data sets can also contribute significantly to bias. So if we try and coerce a really complicated social construct like someone's gender or their ethnicity, and we narrow it down into categorical constructs with only limited options, we inherently cause data to be lost. And that affects certain groups more than others. And if we put all of that together, we have to conclude that data sets, particularly data sets we generate from healthcare services, well, they can be an imperfect reflection of an imperfect society. Now, we've shown that there are big problems with healthcare data across a variety of systematic reviews over the last few years. And I guess the general headline findings across all of our reviews have been that we have this significant gap globally where most countries are not represented. The countries that are most widely represented are predominantly Western, predominantly in the Northern Hemisphere, predominantly white, predominantly wealthy, and predominantly Anglospheric, so English speaking. We also see this pattern of exclusion and I guess missing data within those data sets which actually are available. So really important information, categorical information and demographic information, things like people's age, their sex, their gender, their race or their ethnicity. Often that's just not reported. And when it is reported, it's less accurate for certain groups than for others. And important concepts like consent and ethics and data protection, public and patient involvement are just not really very often considered. And we've shown that these patterns are persistent across a whole bunch of different disease areas, including mammography, ophthalmology, COVID-19, heart failure, skin cancer, and then work by other groups has shown that similar patterns are present in biosignal data sets and also in clinical text data sets. So this is clearly a data set and healthcare problem rather than a specific disease problem. And we term this health data poverty. So it's a multi-layered problem. It's a lack of reporting of attributes, but also a lack of diversity within attributes. And health data poverty is basically the inability of individuals, groups or populations to benefit from these data-driven technologies, things like AI, because insufficient data that adequately represents them. So I guess all this begs the question, well, what do we do? What now? Well, I guess one key message is that there's no such thing as a bad data set. Well, all data sets have context. They're useful for certain tasks, perhaps, but a data set which is useful for this one thing over here can be fundamentally useless for a different task. And so it's all around recognizing the strengths and limitations and benefits of certain data sets and using them in context. So we need data sets to be better documented, better constructed, but also used appropriately for the context that we're trying to solve. So that leads us on to Standing Together, which is an international consensus process that we've been leading over the last few years to develop recommendations on the composition, so that's who is represented, but also transparency, which is how decisions were made during data set curation and how data should be used to evaluate and create medical artificial intelligence. In terms of how we made these recommendations, well, this is a scientific endeavour. So we started off with what is already known. So we conducted a scoping survey of experts around the world and also a literature review to condense down the key messages and learning from what's already out there in terms of recommendation and guidance. And we drew from those various sources of information and produced a short list of candidates' recommendation items. We then spoke to a series of international experts as part of a modified eDelphi study. So we presented this list of candidate items through a series of online surveys and asked experts to comment on those items, but also to up and down vote them. And through a series of 3 votes across about 3 months, we modified those items and came up with a final list. And then we held an in-person meeting over 2 days at the University of Birmingham, and we discussed and deliberated and disagreed and then finally agreed on what was the final set of recommendations, which was released last year. As part of Standing Together, we have drawn on the expertise and experience of over 350 representatives from 58 countries across our various different work activities. And we recognise that this is not a completely full map, so there are still countries and cultures we haven't heard from, and so that work is very much ongoing. In terms of what the recommendations look like, well, they come in 2 parts. The first part, which is aimed at those who are producing healthcare data sets, is called Recommendations for the Documentation of Health Data Sets. And these recommendations consist of things like guidance on reporting of the groups present within data sets, so that you should provide a summary of who is present in data sets. And you should also highlight any groups that you know to be missing from the data set, if that is the case, and why they're missing. On attributes, one of the items that we have is that we should explain as a dataset curator what attributes have been coded, condensed, modified. So if you've condensed gender, which is a multi-plural kind of construct, into binary male-female, then you should explain how you've done that and why. And we also ask people to explain about any biases that may have been caused or exacerbated by the way they acquire and process data. And then on the other side of the recommendations is dataset use standards. So this is aimed at people who are actually producing healthcare algorithmic systems, or those who are evaluating them. So some of the items in this set of the recommendations are around things like identifying contextualized groups of interest. So individuals and groups who are already known to be at risk of harm in the disease area you're focusing on. So if you're working in a particular disease A, which groups are most affected by that disease and which groups have the worst health outcomes. And then later items in this set of the recommendations talk about making sure that your algorithm doesn't exacerbate health inequalities for those people, but also recognizing that it's not just about not worsening health outcomes. You also need to nudge towards better health outcomes. And when you do identify a risk or a problem with an algorithm, well, what's your mitigation plan to try and reduce that moving forwards? Now, much of the work we do, we simply couldn't do that just as a group of scientists sitting in a room talking to each other. We really need to hear the voices of the underserved groups and communities we're trying to help and to amplify those in the work we do. So early on in the project, we formed the patient and public subcommittee, and we also worked with patient co-investigators and an international advisory group to make sure that the recommendations that we've produced have importance to patients and the public in the UK, but they also have relevance across different cultures and concepts, because it's no good us talking about things that matter to us in the UK when we're trying to solve a global problem like digital health inequity and health data poverty. We've been really proud and privileged to have already, in the early stages of the dissemination phase of this project, see some buy-in from important regulatory and legislative stakeholders internationally. So UK governments has pointed to our recommendations a few times. We've worked extensively with the UK's medical device regulator, the MHRA, who also reference us in various outputs from their work. The government responded to the recent Equity of Medical Devices independent report, which also mentioned the standard scale recommendations. And the recommendations also get a call out in the Medical Research Council's guidance on making sure that funding is allocated appropriately. So I guess that's probably enough from me for now. I'm happy to take any questions. I guess we hope that by improving our data foundation, that we can ensure no one's left behind as we develop and use AI in healthcare. We're indebted to all of our contributors, our working group and our patient advisors over the last few years for all of their help and assistance. And if you'd like to learn any more about these recommendations and how they might help you in your work, you can visit our website, which is www.datadiversity.org, or you can scan the QR code and I can pop a link in the chat in a second to the website as well. So thanks very much for your attention. I'll stop sharing and happy to